Great, thank you so much. Great, so good afternoon, everyone. Thank you so much for joining us for today's Lunch and Learn series. My name is Iman Gibson, and I'm the Chief Clinical Officer at Integrity House. Just a brief background about us. We are a nonprofit substance use and mental health treatment provider in New Jersey. We have locations in 5 counties throughout the state, and we offer a full continuum of addiction treatment, outpatient mental health, through our certified community behavioral health clinic, prevention services, supportive housing, and a wide array of other, care coordination services. We have been providing services to New Jerseyans for 55 years, so we really hope to continue to serve the community for the many decades to come. So as we wrap up National Recovery Month, we feel this topic today was very essential, the topic of harm reduction. We are joined today by our esteemed colleagues in the field who will share their experiences on integrating harm reduction practices in the substance use setting, both from the perspective of challenges as well as opportunities. Unfortunately, as all of us on this call know, the overdose fatalities continue to be well over 100,000. With harm reduction practices, they're not new. They have proven to be successful with different groups in the past, but not so widely accepted and adopted in the substance use field, which has been abstinence-based for many, many years. So we're happy to bring this information and just kind of take a look at what we could be doing different and what we could do to really help those that we serve, and just reevaluate our orientations and offerings for those that we serve. So I want to introduce our panelists. We are joined by Dr. Svetlana Spiegel, who is an associate professor at the Department of Social Work and Child Advocacy at Montclair State in New Jersey, which is also where I graduated from. Her research focuses primarily on children, youth, and families involved in the child welfare system and other systems of care. Dr. Spiegel teaches graduate level social work classes and serves as the coordinator for harm reduction education initiatives in her department, which she will share with you about once the presentation begins. We also have Shanta Collins, who is the owner and managing partner of a medical group and is a psychiatric mental health nurse practitioner at Rutgers University in their care center focused on addiction medicine. Her background includes success in academic and private practice and philanthropic arenas. Shanta is passionate about being a part of the greater good and she believes that the art and science of kindness, humility, gratitude, and respect is a part of her DNA, which is a great makeup there. Shanta's traveled over 25 countries, and she's committed to humanitarian and disaster relief work, and has worked in the city of Philadelphia. Shanta believes in the cause to support addiction medicine in order to engage others and include people with all walks of life. Lastly, we have Kelly Labar, who has over 20 years of experience in chaotic substance use and return to balance. She started in the substance use field in 2015 after working in the medical field for 10 years. Becoming involved in local recovery advocacy groups and volunteering as a peer. From there, Kelly found her passion in harm reduction, primarily focusing on the unhoused, those actively using substance use, LGBTQIA+ members, and sex workers. Kelly has worked for nonprofits providing peer support, mobile street outreach, naloxone training, harm reduction kit distribution, and certified peer recovery specialist class facilitation. Kelly has worked tirelessly to gain trust in the community and has also found a peer-led street street-led outreach nonprofit providing wound care, harm reduction supplies, peer support, and case management with a team of volunteers focused on autonomy, empathy, trust, and dismantling the racist war on drugs while empowering people to access services. She has established numerous professional relationships with prevention organizations, medication-assisted treatment providers, mental health organizations, nonprofits, grassroots organizations, and colleagues. She's also rallied for peer-led harm reduction services at budget hearings, testified at the State House against bills fueling the racist war on drugs, spoke up against SOPA at town halls in favor of opening methadone clinics in her hometown, and presented on structural stigma against people who use drugs. And she is a part of Montclair State University's Harm Reduction Advisory Council. So we have a lot of experience with us today, a lot of knowledge and expertise, and we are so grateful for our panelists. We will go ahead and start our presentation. I'll pass it off to Dr. Spiegel. We ask that you please hold off on your questions until the end. But as you have questions, just put them up and we will address them after the presentation.
So let me just share my slides and let me know if you see them.
Yeah.
Okay, perfect. So that telling you a little bit about what this webinar is going to be focused on. We will start by talking a little bit about our harm reduction initiative here in Montclair State. It's a relatively new initiative. We have started that last year. So we'll talk just a little bit about that, a few words. And then we'll begin with our webinar. What we really want to talk about today is not necessarily about a particular harm reduction intervention and in-depth knowledge about it, but really how to take the harm reduction focused counseling principles and incorporate that in your day-to-day work, right? So we want to acknowledge the fact that folks are working in a variety of different organizations. And one of our goals is sort of to break a little bit the dichotomy between harm reduction and abstinence-focused interventions, right? And maybe try to see how we could have a conversation about integration. So just a little bit about us in Montclair. Our initiative focuses on harm reduction education, research, and also community engagement. We have a new graduate certificate program designed both for current and for professionals in the field, and it's called Harm Reduction Approaches to Substance Use. So take a look at this. It is on our website, and those of you who are interested in this domain of harm reduction, we would love for you to take a look at our certificate where we talk a lot about this. The certificate is fully online and asynchronous as well, so it is a good fit for professionals. And then in addition to that, we engage in research related to harm reduction. We just completed a needs assessment of harm reduction related needs and gaps in the 7 northern New Jersey counties. So we will be presenting about that very soon to the community. And then we provide these continuing education courses such as this one for free to organizations who want to learn more about harm reduction and want to engage with this domain. And we also have some events on campus and off campus where we engage community, where we engage treatment providers and also policymakers in these conversations. So that's us. And if we can, before we start, it always helps me to know who is in the room when I do this presentation. It'd be really helpful if you could just put in the chat your title and your primary discipline. Is it social work, psychology, counseling, nursing, peer, whatever it might be. And then how many years of experience you have in the field. That would be great, just so we can kind of see who is in the room with us. And then Kara, if you could, I don't know what needs to be set up for our activity, but for the poll, but if there needs to be a setup, now is a good time. All right, so I could see some folks writing. Don't do the, maybe we did the poll a little bit too soon, I'm not sure. Okay, so I see a couple of folks here writing about their expertise. We have some physicians, we have advocacy coordinators, program managers, social workers. So really a variety of different fields, substance use counselors, more social workers and mental health clinicians. We have a variety of different expertise here in the room, which is wonderful. Okay, so what we really want to do first, before we kind of start with our slides and really content is to do a brief activity just to get a sense about how folks think about harm reduction versus abstinence. So you will see a poll that will appear on your screen, and it has a couple of statements in there. And if you could just say if you strongly agree, disagree, strongly disagree with each of these statements, so we could then see what people think about harm reduction and abstinence. I think that will be a nice setup for our discussion. Can everybody see the poll? I don't see it yet.
Yeah, it's there.
Okay, perfect.
I can't see it either.
It does appear as a separate window, I believe. So, you know, outside of your Zoom screen that you see, because I see responses coming in. So one window should be the presentation and your poll should be a separate window. Do you see the poll responses, Dr. Spiegel?
I do not know.
I have them. If you want to, whenever you're ready, I can share the responses if that would help, since you're not able to see it. I'm not really sure how to fix that right now.
No worries. Oh, I actually can see them now.
Okay, great.
How do I share them so that they appear on the screen? Can I do that, or that's not something we could do? If not, I could just walk us through them.
Once all the responses are in, we can share with everyone. So just let us know when to close the poll, and the responses will show for everyone.
Okay. It sounds like I didn't see any more responses coming in, but let's give folks just a few more minutes to do this. Okay, I think we're good to go to start sharing. Should I unshare my screen so you could share, or you could share it anyway?
So Ronnie, are you able to share the poll without?
Does everyone see the results?
Yes, I can see them.
I can't see it. Okay, so as you could see, we sort of had a couple of different statements just to get a sense how folks think about and as we go to kind of some of the more nuanced around certain harm reduction interventions, which we commonly see in the field as we do these presentations. So what is harm reduction? Just kind of a general background for those of you who are new to this. This is a set of strategies, right, with drug use rather than requiring abstinence. So harm reduction interventions do not require opposed to abstinence, right? They just recognize that abstinence is not going to be a goal for everybody who we work with, right? So and health. Umbrella. So most of you know this, it includes a variety of different things, and some harm reduction interventions are much more accepted in the field. It's been more broadly accepted in recent years than it used to be. And certainly there's more consensus around medication-assisted treatment as compared to some of the other harm reduction interventions. As we progress towards things like syringe exchange and certainly safe consumption rules and other more controversial harm reduction interventions, that's where we see a little bit more disagreement. But today, what we're going to focus on is essentially harm reduction providing some of these interventions directly, but we still want to use some of these principles in our work because we recognize that clients who come to us are not always ready, willing, or able to continue to stop using altogether. So why is it important to have this orientation? Because we know, as I've said before, abstinence does not work for a lot of clients. And what we see in the field is that it leads to disengagement, right? So if a client comes in and it's a complete abstinence-focused program and they're not there, at some point they might drop out and they might disengage from services. So incorporating these principles of harm reduction can increase engagement and it can keep people in treatment, even those people who are not ready to stop using, right? But we still want them connected because when they're not connected, we miss out on an opportunity to engage them in the kinds of services that could still be helpful and still kind of better and improve their lives and reduce risk, even if they're not necessarily willing or able to stop using altogether. So what does research show us about this? And we're going to hear from our speakers in a second about this, but really about a third of clients who seek substance use treatment will drop out within the first month. And a lot of them will drop out within 3 months, so much more than a third. And that is taken into account that most people who need addiction treatment will never seek it to begin with, right? Or not going to seek it at all. So we really are losing a lot of clients. And when studies sort of try to look at, well, why are we losing so many people? What is going on? Clients report that not feeling ready for abstinence or not feeling able to be abstinent is one of the most important reasons for disconnection, right? And also not feeling connected with the provider. We know therapeutic alliance is really important, right? So not feeling that connection is really, really critical. So harm reduction focused engagement and really conveying that we are meeting people where they're at. We're willing, we want to start where people are at. That is something that can help and address these engagement challenges and really help keep people in treatment. So Kelly and Shanta, I really want to maybe hear from you in terms of how do you convey that stance of meeting people where they are in practice, right? So these terms sound really good in theory, but how do you do that in practice? Maybe Kelly, we could start with you, or Shanta. Yeah, go ahead.
I've been having problems with my, can you guys hear me okay? Okay. Basically, one of the things I could speak to would be building trust. Trust is absolutely essential. And building the trust starts with being non-confrontational as a provider or clinician, being, try to reduce any barriers like your personal thoughts or opinions, because really it doesn't matter. This person sometimes, generally speaking, maybe at their end, at their last little bit of hope that they had available, they decided to to take it upon themselves to reach out and maybe accept, help or reach out to a center for guidance. And so I do feel, as Svetlana has said, a lot of what we do, especially, in clinic, from my perspective in psychiatry, is really reducing the barriers of any stigmatism, personal thoughts that we may have that are preventing us from being open-minded when receiving the information, and be as non-judgmental. I am a person who I maintain a strong facial presence, meaning that I can make faces, not intentionally, but I just, oh, really? And I express myself quite well just from my face alone. I don't actually have to speak most times. But I have learned that I try to laugh a lot. That's one thing I feel like is important. And having food. I mean, I know these things sound, but snacks. I always have snacks, always have food, and I always have water. It just you fill the belly, food, water, shelter. A lot of people, those are basic essential things. So I try to go in and develop a trusting relationship from the door. And I also am a hugger. I know that's probably against the rules of psychiatry, but don't tell anyone. But I hug. I mean, and that's not always the first time around. I'm just like, sometimes we just all need a damn hug, guys. So let's bring it in. And that's kind of that's how I roll. I speak for myself.
Thank you, Shanta. Kelly, do you want to weigh in as well?
Yeah, thank you. Everything you said, Shanta, absolutely love it. For me, meet them where they are, that's kind of turned into a catchphrase, right? So we have to make sure we meet them where they are, but we don't leave them there. And as a peer, for me is letting people know, like what Shanta said, I'm a trusted ally for you, and I want you to be safe. And as soon as that is established, then that honest help them along the way. So meeting them where they are is, you're not coming in with any preconceived, this is what I want for that person. You're trying to listen to them and connect with them so they know they're being heard and seen. And then folks really value that kind of interaction.
Thanks, Kelly. I appreciate that perspective. And this is really kind of what literature and research tells us well in terms of communicating that harm reduction stance. So first of all, as both of you noted, it's lowering that threshold for treatment, right? We are being substances who should automatically lose custody of their children. And again, some folks were neutral about that, but most people disagreed and strongly disagreed. But then as we go to kind of some of the more nuanced items, for example, here, people who live in government-funded housing must be drug or alcohol free. You see a little bit more agreement there, right? And more people who are neutral and less people agreeing or strongly disagreeing with that. This one, it is not acceptable to teach intravenous drug users how to sterilize their injection equipment. Again, most people agreed or disagreed. Disagreed or strongly disagreed, but then there was some agreement and neutrality around this. So I think overall, it seems like, given the fact that you're here, some of you have explored these interventions already and are thinking about them and are more positive towards them. But there's certainly some ambivalence around certain harm reduction interventions, which we commonly see in the field as we do these presentations. So what is harm reduction? Just kind of a general background for those of you who are new to this. Essentially, this is a set of strategies, right, with the goal of preventing negative consequences associated with drug use, rather than requiring abstinence. So harm reduction interventions do not require abstinence. It's not that they are necessarily opposed to abstinence, right? They just recognize that abstinence is not going to be a goal for everybody who we work with, right? So the focus is on meeting clients where they are at and working towards safety and health. What that means, it could mean stopping use altogether. It could also mean not stopping use altogether, but still working towards safety and health in other ways, right? So we will talk about some of the other treatment goals that could be applicable to that. And harm reduction is a broad umbrella. So most of you know this. It includes a variety of different things. And some harm reduction interventions are much more accepted in the field than others. For example, medication-assisted treatment has been more broadly accepted in recent years than it used to be. And certainly there's more consensus around medication-assisted treatment as compared to some of the other harm reduction interventions. As we progress towards things like syringe exchange, and certainly safe consumption rules and other more controversial harm reduction interventions, that's where we see a little bit more disagreement. But today, what we're going to focus on is essentially harm reduction oriented counseling, right? Because a lot of the interventions, and when we talk about them, we don't really think about, well, how can we use the principles of harm reduction oriented counseling, even if we're not a syringe exchange site, if we're not necessarily providing some of these interventions directly, but we still want to use some of these principles in our work, because we recognize that clients who come to us are not always ready, willing, or able to continue to stop using altogether. So why is it important to have this orientation? Because we know, as I've said before, abstinence does not work for a lot of clients. And what we see in the field is that it leads to disengagement, right? So if a client comes in and it's a complete abstinence-focused program and they're not there, at some point they might drop out and they might disengage from services. So incorporating these principles of harm reduction can increase engagement and it can keep people in treatment, even those people who are not ready to stop using, right? But we still want them connected, because when they're not connected, we miss out on an opportunity to engage them in the kinds of services that could still be helpful and still kind of better and improve their lives and reduce risk, even if they're not necessarily willing or able to stop using altogether. So what does research show us about this? And we're going to hear from our speakers in a second about this, but really about a third of clients who seek substance use treatment will drop out within the first month. And a lot of them will drop out within 3 months, so much more than a third. And that is taken into account that most people who need addiction treatment will never seek it to begin with, right? Or not going to seek it at all. So we really are losing a lot of clients. And when studies sort of try to look at, well, why are we losing so many people? What is going on? Clients report that not feeling ready for abstinence or not feeling able to be abstinent is one of the most important reasons for disconnection, right? And also not feeling connected with the provider. We know therapeutic alliance is really important, right? So not feeling that connection is really, really critical. So harm reduction focused engagement and really conveying that we are meeting people where they're at. We're willing, we want to start where people are at. That is something that can help and address these engagement challenges and really help keep people in treatment. So Kelly and Shanta, I really want to maybe hear from you in terms of how do you convey that stance of meeting people where they are in practice, right? So these terms sound really good in theory, but how do you do that in practice? Maybe Kelly, we can start with you, or Shanta. Yeah, go ahead.
I've been having problems with my, can you guys hear me okay? Okay. Basically, one of the things I could speak to would be building trust. Trust is absolutely essential And building the trust starts with being non-confrontational as a provider or clinician, try to reduce any barriers like our personal thoughts or opinions, because really it doesn't matter. This person sometimes, generally speaking, maybe at their end, at their last little bit of hope that they had available, they decided to take it upon themselves to reach out and maybe accept, help or reach out to a center for guidance. And so I do feel, as Svetlana has said, a lot of what we do, especially, in clinic, from my perspective in psychiatry, is really reducing the barriers of any stigmatism, personal thoughts that we may have that are preventing us from being open-minded when receiving the information, and be as non-judgmental. I am a person who I maintain a strong facial presence, meaning that I can make faces, not intentionally, but I just, oh, really? And I express myself quite well just from my face alone. I don't actually have to speak most times. But I have learned that I try to laugh a lot. That's one thing I feel like is important. And having food. I mean, I know these things sound, but snacks. I always have snacks, always have food, and I always have water. It just you fill the belly, food, water, shelter. A lot of people, those are basic essential things. So I try to go in and develop a trusting relationship from the door. And I also am a hugger. I know that's probably against the rules of psychiatry, but don't tell anyone. But I also hug. I mean, and that's not always the first time around. I'm just like, sometimes we just all need a damn hug, guys. So let's bring it in. And that's kind of that's how I roll. I speak for myself.
Thank you, Shanta. Kelly, do you want to weigh in as well?
Yeah, thank you. Everything you said, Shanta, absolutely love it. For me, meet them where they are, that's kind of turned into a catchphrase, right? So we have to make sure we meet them where they are, but we don't leave them there. And as a peer, for me, is letting people know, like what Shanta said, I'm a trusted ally for you, and I accept all of you. So I'm not, my first interaction is, I care about you and I'm here. I want you to be safe. And as soon as that is established, then that honesty comes through. Okay, well, this is what I'm doing. When you can establish that honest, trustworthy communication between folks, you're going to be their safe place, right? And that can completely change what someone is looking to do, because they know they have an ally with them to help them along the way. So meeting them where they are is, you're not coming in with any preconceived, this is what I want for that person. You're trying to listen to them and connect with them so they know they're being heard and seen. And then folks really value that kind of interaction.
Thanks, Kelly. I appreciate that perspective. And this is really kind of what literature and research tells us as well in terms of communicating that harm reduction stance. So first of all, as both of you noted, it's lowering that threshold for treatment, right? We are not saying that you have to be abstinent to be in treatment. That's really important, right? It's not to put that barrier up from the get-go, right? And we're communicating that very explicitly to clients. We want to suspend judgment, and that sometimes means working with a client when they're actively using, and they might come to you while they're actively under the influence. Very honest in terms of what that means. How do I feel about this? What are some of the biases potentially and thoughts and feelings that this invokes, and how do I deal with that as a clinician? And then assess motivation, really. I really like this quote from an article I really enjoyed that I included as a reference for you all if you would like to read it. And they say, no one isn't motivated. The question is what the person is motivated for, right? So I think as clinicians, sometimes we say, well, this client is just not motivated to make a change. Whereas a better question would be, is the goal that we're trying to promote the right goal for the client, right? Is that the goal that they're motivated to really engage in? So as part of the engagement work is to assess, right? What is the goal that this client might be motivated to work towards? And that might not be what we think is the most urgent goal for them, right? So it's staying where the client is is also accepting that our goals and what we think is best might really differ for our clients, and they might conceive this completely differently. Other strategies to lower threshold for treatment, right, is also in action. So same day MOUD prescriptions, right, flexible hours. Sometimes clients report, I want to do this, but there's so many barriers in terms of access that I'm just not able to, right? So providing this sort of flexible strategies for clients to engage is really, really important. Telemedicine is critical. And COVID-19 emergency really showed us that telemedicine is feasible, right? It works. So trying to meet clients in that way is also important. And then other things that could communicate a harm reduction stance, having naloxone in your offices, right? Providing naloxone to clients, having hygiene kits, wound care kits, right? Other harm reduction supplies. And this is where I want to sort of say, this is where it's really important to have harm reduction trainings, but also to have open conversations with staff. What are we as staff willing to do, right? What are some of the things that we feel comfortable with? We might not feel comfortable educating clients about safe injection yet, but we are comfortable providing wound care kits. We are comfortable providing naloxone. We're comfortable providing hygiene kits, right? Starting where you could start is really, really important, right? We say that about clients, starting where the client is, but that's also true for agencies, right? Starting where the agency is in terms of harm reduction acceptance. And also recognizing that agencies can't provide everything, right? And certain agencies will be willing to do some things, able to do some things, and not others, and that is okay. Empathy and acceptance is really important. So one of the things that I think providers get hung up on a lot is that respect for self-determination when it comes to drug use. And I think a lot of the times the stance is, well, if this person has a substance use disorder, they can't be using anything. They really shouldn't be using any drugs, right? They should not be using alcohol. And according to sort of the harm reduction stance, we really have to accept that even our most vulnerable at-risk clients can and will make some substance use related choices for themselves, right? So accepting that they have that agency and have that self-determination and guiding them through that decision process is really important. Another thing that's important is sort of neutrality towards drug use. It doesn't mean we are accepting drug use, but we are not condemning it either, right? Because once we come with a stance that we condemn any use, right, we're going to lose some clients and they're going to disengage. Or they're not going to tell us what they're doing, which also happens a lot. So coming with that neutral stance, it's not that we're conveying that using substances is the greatest thing since sliced bread, right? But we're also not demonizing, not saying, don't do anything, you can't do anything, this is terrible, because that is not helpful for our clients. And I want to kind of hear from Kelly before and Shanta before we continue, but stigma is one of the things that really affects clients and their engagement. And I wanted to ask you how you've seen in your practice stigma showing up in treatment. So what kind of behaviors, issues you've seen in terms of service providers really conveying a stigmatizing approach towards drug use?
Unfortunately, I think we've all heard a lot of the same things from, coworkers. I have a bit of a cough, so don't mind the cough drop in my mouth. I think we hear a lot of same things, right? We've heard people say, oh, they've been here a million times before, right? Frequent flyer. Oh, they don't follow through. They're saying the same old things. And I think the biggest issue with that is we're putting all the blame on the people that are seeking help. So instead, we should be asking ourselves, I'm sorry.
No worries.
Oh my goodness. Instead, we should be asking ourselves as service providers, as peers, you know, how is the system failing them? What barriers do they have that were not being addressed? And addressing that as treatment providers, we also are stigmatizing as a system, our clients and ourselves, and being able to open and honestly look at that for the best benefit of the people we're trying to help.
Thanks, Kelly. Shanta?
Yes, thank you. I want to say, I am asking that we all, if we were to take one thing, part of many things from this wonderful presentation, today, is if we ourselves, as providers, as clinicians, as people in the field, can discourage people from saying, dope head, addicts. I am tired of hearing that. And it's coming from professionals that work and do this every day. That's the first thing I just want to say, please. And also, I want to, although I practice in private practice, and also I cover as chief medical officer in a couple of facilities, specifically like psych and a lot of substance use disorders histories, and schizophrenia, schizoaffective patients that are suffering in those disorders. I sometimes do the pound, and also I get permission before there's any engagement of a side hug or anything like that. So I just wanted to make that clear. There's not, although I'd love to, in the world, you have to be still respectful of personal space. So I wanted to make sure sometimes a pound is I also have federal prisoners as my clients. So back to the words that we use, and also how we see our clients has to be as open-minded as possible. When it comes to the stigma, we're able to articulate and also communicate that this is not only inappropriate to say, but we don't have to necessarily call the person out at that time and in that moment. We have to just say, you know what, for us to get better and grow the field that we are in, to help more people and see more people are choosing abstinence, we have to change our attitudes about how we see them. And we have to change our attitude, how we approach this. And if there are other things, like you said, Solana, which I love, even though it may not want to necessarily be a site where, needle ejection sites or drop off site, we can offer wound care, we can offer packs of supply, where do you go? And these are teams that are offering care in the community on the street medicine. So we can be a beacon of change through the fact that we are also sharing information, and also that helps reduce, stigma through education. The other thing I wanted to bring up is when we are addressing clients and also each other, really, a lot of times people will say, "Hey, what's wrong with you?" There's this book that, instead of saying what's wrong with you, you need to say or ask what happened to you, because 9,000 out of 10 times, and I swear, for practicing for 15 years, if I can't see, one of the main things that I hear was childhood molestation and travesties. In addition, just call it PTSD. They want to summarize it, but PTSD, child molestation, is apologize, but that's some heavy stuff. And you can summarize it as PTSD, but I really differentiate and separate those. Anyway, so that's something to be aware of. As the stigmas, we need to reduce them, but we need to check ourselves and thank you.
Thanks, Shanta. And in my conversation, since I've started doing this work with some folks who have used substances chaotically before, the nonverbal behaviors that convey stigma are also important, right? So clients will say something like, I come in, and yes, I've been on the street and I haven't had particularly easy time, right, in terms of personal hygiene, but the provider would then sit very far away, the state that with you being here. So just verbal behaviors, it's also some of the things that we do that really make clients feel unwelcomed, make them feel ashamed, and make them feel like they're just, we don't want them there. So as you think about kind of stigma verbally, also think about some of the other behaviors that convey stigma. I both Kelly and Shanta that language matters, right? Some of our assessments that we use and the questions on our intake are very stigmatizing if we think about them. So I'm going to give some examples in terms of changing language a little bit later on. But it's really thinking about how could we change our language and also our nonverbals, right? To make sure that clients are feeling welcomed. The other thing that sort of a harm reduction oriented counseling really advocates for is we're not saying that clients have an addiction issue as much as we're saying they have a relationship with substances, and some relationships are more challenging than others. And that also allows us as clinicians to accept that a person might be able to moderate their alcohol use, but they cannot moderate their opioid use, right? So there could be different relationships with drugs. And understanding a little bit better what that relationship is for a client could really help us think about how can we promote safer use for this client? How could we promote some of these other goals? So in terms of kind of exploring that, that's something that's really important. The other thing that that is important is really the ability to differentiate between behaviors that are immediately harmful and need to be discouraged, right? And then behaviors that are not immediately harmful, and we could talk about them, but it doesn't necessarily help our clients if we take a very strong discouraging stance towards them. So for example, if your client is coming to your office under the influence and they are driving, obviously this is something we cannot accept, right? This is not, even if we're very harm reduction oriented agency, this is an immediately dangerous behavior to them and to the environment. But there could be other situations where that's not the case, right? And if a client is, say, using alcohol safely in other situations, we could talk about that and sort of see where that meets us. And again, this is a quote that I like: sobriety does not guarantee an appropriate conduct. Likewise, intoxication does not guarantee an inappropriate one, right? So just because a person is using doesn't always mean that it's going to be dangerous for us, right? It's going to be dangerous for their environment at this particular point. And that is something that we really should think about, rather than automatically condemning all use altogether, because that is how we're going to lose clients. In terms of language, it's, as I've said, some of our assessments could use very stigmatizing language, and it helps to think about how can we reframe some of these questions. For example, asking a client something like, "Oh, so you share needles, right?" is automatically putting them on the defensive. Instead, you could ask something like, how many times have you used a syringe after someone else, right? Or have you used a syringe after someone else? And that doesn't assume sort of this stigmatizing approach to this, but just kind of conveys that we want to know. Also asking something like, do you engage in sex with multiple partners, right? Very stigmatizing question. I've seen this on assessments in a variety of different domains. Instead, consider as something like, tell me about your sexual partners, right? And kind of just listen to what the client is talking with you about. And that could give you information about their gender and about sort of some of these other things that you would want to assess as a substance use provider, right? If there is any high risk behaviors and things like that, but just asking an open-ended question about it rather than really using a very stigmatizing way of asking questions. And then thinking about using words deliberately to normalize positive responses, right? So you want to make your client feel confident and comfortable that they could share with you what they're really doing. Because once they are not sharing, we can't help reduce the harms, right? And we can't really help them get where they want to be. So using words deliberately to really normalize, I really want to know, right? I really am going to accept whatever you bring to this session, right? Whatever you bring to this engagement, I want to be accepting of that. I've heard clinicians say, and students certainly that are new to the field, right, and are coming and engaging in substance use agencies, and they would say things like, well, I am not comfortable. This person is clearly high, and I don't know what to do. I'm not comfortable in this engagement, right? So I am going to tell my client that they can't come to me when they're high because I am not comfortable speaking with them when they are. And that is something that I think a lot of us feel, right? And sort of instinctively think, oh, this is not okay. And it's useful to ask, is there a real danger at this moment for me, for the client, or for somebody else at this agency? And if there is, as we've said, any behaviors that are immediately dangerous, we certainly don't want to accept and entertain. However, a lot of the times, a person can be high or actively using, right? And there isn't a danger, right? And that just makes us uncomfortable, but there isn't a real danger to you as a clinician, to others in the agency, or to the client themselves at this particular point, right? So what does that mean, right? And how do I deal with my discomfort without passing judgment? Now, a lot of you will say, well, my agency has constraints. We have regulations, we have state regulations, we have agency regulations. There's certain things that we just can't do. And that's okay. And again, what I usually tell my students and other kind of new clinicians that kind of bring this up, you have to reflect on that intentionally and honestly with your client, right? So what is the most ethical course of action that you could take given the constraints of this agency and given the fact that you still want to maintain a harm reduction stance, right? And it might not be everything that you would want to do. We have to adhere to our constraints, but it could still be something. I want to ask Shanta and Kelly, because one of the things that folks bring up a lot is working with mandated clients, right? And how that really complicates the harm reduction stance and dynamics. And I wanted to ask if you've had those experiences working with mandated clients and how you would still bring harm reduction stance to working with those clients.
Yeah, so I thank you, Svetlana. Yeah, I definitely have experience working with patients who come in under the influences of what you're referring to, Svetlana. And sometimes it's a mix of that, and also if they're in a high mania or in having positive and negative symptoms, more positive symptoms related to their schizophrenia or schizoaffective disorder. So I do I don't necessarily, it's not about normalizing it. It's just that what I do is just try to be patient and again, try to, if they're able to pay attention and also engage during the session, not just there for a medication refill. I have patients that may get up as we're talking and start touching the walls. May start saying different things. I don't feel, and again, I have built this trusting relationship with this person, and I feel like I actually feel happy that they feel comfortable enough to not feel afraid to, if they're having those moments. And then I've learned how to bring them back as we are in session. That is so important. And I also know that I had one time on one particular client, kind of very same person, and we went to take the elevator to go down to get something to eat in the same building, with, it's a padded, but when he gets in elevators, like I said, in certain spaces, I know how he, behaves. And again, as we're talking, he's touching around the walls. That's just him needing to feel comfortable, and also how he engages with others. So it's just more, to me, it became more of an experience more than it is, how do you don't really know until it happens to you. So I don't know if you can prepare for it, because you just almost have to just kind of be, sitting there just listening. Don't let the heart rate get too fast, because sometimes that increases your anxiety. I just feel like I just generally will try to do my best. If it does become to a point to where it's just, this is not, there's nothing going to come as far as outcome or anything like that, or we're not meeting our goals at this moment, let's take a break. You can go sit back in the lobby, or I'll be right back. Or something like that. But again, I feel like this is a lot more to do with like someone with experience versus not having experience, and comfortability. Because this same client the same client that I'm speaking of, they called the police on him, had him escorted out and taken to the crisis center. But I don't do that because I don't feel like he's in any danger to hurting me or anyone else. But he was having those moments, but you have to know how to engage him. That's just to me, again, go back to experience. Sorry for so long.
No, no worries. Thank you.
Thank you, Shanta. I definitely have experience working with mandated clients. I think, you know, just with any relationship, it's honesty, right? So you have to be clear about, you know, what your responsibilities are in that relationship. But then also, you have to build trust. So, you know, one thing I do is we set those boundaries, and but I also make sure that the person I'm working with knows I'm their advocate, I am their ally. I am going to back them up as much as I possibly can. And also, a lot of people don't like when I say this, but I let people lie to me. I'm not going to call folks out on their lies. I let them lie to me. And you know what? Every single time, because I have that relationship, they come tell on themselves, right? I have written letters to judges for folks. I have gone to court with folks. I've talked to probation officers. I put in the work. And that's the other thing when I say that, like, listen, we have certain guidelines. How can we keep you compliant? But also I'm going to fight for you. And then when I bring up what I've done and I'm serious, I mean it, I'm going to be there for you. Again, it helps build the relationship and the trust. So they are going to be honest. Because especially with mandated clients, just like with a lot of abstinence only treatment providers, they demand perfection. It's you know, it's very, very, very difficult. I would say it's practically unattainable. And we have to be able to advocate for folks, because a lot of times the folks we're working with have been fighting so hard and in survival mode for so long that I can put on those gloves for them, right? And I have to make sure that they know that so they can trust me and we can work together.
Thank you, Kelly and Shanta. I really appreciate that perspective. And I think you're right. It's about being honest about the constraints and advocating for change where change is warranted, right? Like really, I think, as you've said, putting in the work as a clinician, I think it's really, really important. So one of the things that harm reduction oriented counseling strategies really don't agree with and don't encourage is drug testing, right? So drug testing is considered to be punitive, and punitive approaches is something that harm reductionists try to avoid because we recognize that it doesn't necessarily help clients to take that punitive approach. So, but then nonetheless, we also know again that there are constraints and there are requirements sometimes that require drug testing. So as an agency, I think it's really important to reflect on the pros and cons of requiring drug testing. Why are we doing this? What are we achieving? What are we hoping to achieve? Is what we're hoping to achieve what we're getting, right? How do we really do this differently to achieve the goals that we're thinking to achieve with this? And we know from research that, as Kelly said, clients who feel a stronger therapeutic alliance are more likely to tell the truth. Even if they lie initially, they're more likely to come back and say, you know what, I wasn't honest. I actually did do this, right? So that therapeutic alliance and creating that engagement is really, really important. Also, the stance on testing is it is best used when it can change management, right? So there are certain instances where drug testing is necessary, right? Like if clients are on MOUD, it's important to know what else they're doing. But if testing is not going to necessarily change management in any way, that's when the question is, why are we actually doing this and what are we trying to achieve? Are we just being punitive with our clients, or are we actually trying to achieve some kind of a goal? And if so, are we achieving that goal with this approach? We also know, again, I've mentioned COVID-19 before, and during COVID-19, the frequency of drug testing was reduced greatly. So we know we could do that, right? We know it's feasible to reduce drug testing. We also should be mindful of when drug testing has a particularly punitive context. And that is when you work with child welfare involved clients, right? Where drug testing can have real implications for custody and for their engagement with the child welfare system. And then obviously working with justice involved clients as well, right? Where drug testing is really, really important for their life and what is going to happen to them next. If you are an agency that requires testing or thinks that testing is what we need to do, ask the client, what substances do you expect to appear in your result, right? So avoiding the dynamic of catching the client is really important. It's not doing anything good to the therapeutic alliance and to your trusting relationship if you're trying to catch them lying, right? We know our clients are not always truthful with us, right? So it is always best to have that conversation. What do you think am I going to find in this test? What do you think is going to appear? And it also gives them an opportunity to disclose use, right? To disclose the relapse, to disclose that they've been doing something they said they didn't do. So with this in mind, I'm just wondering if you work at an agency that uses drug testing and why you use that as an agency. So maybe you could put some of those responses in the chat. Just does your agency require testing, and why do you require that? What is the goal?
Can I say something, Svetlana? Legally, for me to prescribe Suboxone, the DEA requires it. So that's part of it, the DEA. And then also, I guess they use it also in a care center. Also, it's just accountability because, it's just the one thing that, we've discussed as clinicians who prescribe Suboxone is that, people feel, as reported, they feel like glorified drug dealers legally, because it's like, okay, well, I've been giving this person in this facility Suboxone for 10 years, but yes, Suboxone's never in their system. And it's like, well, what are we doing? What can we do differently? Now, that's when we already offer you Sublocade, where we administer in the office. But who's really coming, like methadone? They come every day. I mean, you can do that. But a lot of times you then start seeing people no longer coming because the challenge, and again, they have everything in their system but Suboxone what they're being prescribed, but they'll have other substances. And at some point, you just can't allow that. So from a legal standpoint as well, I'm just letting you know, maybe that's part of it.
Yeah.
Okay.
And I see somebody else wrote here that they work in an agency that requires random drug testing. I'm assuming you're not the only one, Caitlin, that works in an agency like that. So what are some of the other reasons? And maybe Kelly, you could also weigh in on kind of what you've seen in the field, why people agencies require testing, and kind of how you've seen that play out.
I've definitely seen, I would say, excessive testing. So like, what Shanta said, there is some mandated things, but then there's going above and beyond of where you're testing people 3-4 times a week, calling them in, the occasional random testing, like someone just put in the chat, if you're prescribed medications, make all those things, like I get, but are you doing it? What is the benefit? You're doing it to be in compliance with DEA or your standards. And if the company standards is why you're doing it, and those are excessive, then again, that's something that needs to be reevaluated from a system standpoint. And then, like you said, you're having a punitive program for folks that you're looking to help and not catch, right? So you want to have the conversation before that comes up. So again, trying to reevaluate something that you might be doing on like autopilot, right? To see if it's really beneficial or not.
I appreciate that, Kelly. And sometimes I've heard, and I think Shanta, you mentioned that as well. Sometimes agencies would say, we do this for accountability, right? So obviously clients who you have to do this with, and clients on MOUD, right, and medication, that is a different story, because as I've said before, when testing can change management, right? Management of medication or some kind of other treatment implication, it is important to do that, and it could be a legal requirement as well. But then sometimes when we say we're doing this for accountability, right? Do we really achieve accountability with that? And that is a question that I think we as agencies have to ask ourselves. And sometimes the answer is yes. And sometimes when it's excessive, the answer might be no. And what we might be achieving instead is disengagement, right? Because if we do have that dynamic of catching the client, if we have excessive punitive testing, what might happen eventually is they're just going to leave. They're going to be like, well, I don't want to be in this situation again, and I'm just going to disengage. And once we lose them, they're at much higher risk for a variety of adverse outcomes. So keeping them in treatment is really important. And that's kind of something for agencies to ask themselves, well, why are we doing this? Are we really just doing what we're required to do? Do we believe that promotes accountability? Does it actually promote accountability? Does it change management, right? So really be deliberate with these kinds of approaches. And I've seen other folks here weighing in the chat as well to kind of, sometimes it's helpful when it's used the correct way. And that is true. And that's kind of what harm reduction stance really believes, is that sometimes it's either necessary, legally required, or could be helpful for clients. The point that we're really trying to make here is have those intentional conversations, right? Having kind of not just accepting policies because they're there, but really thinking about what are we trying to achieve and are we really achieving that? In terms of assessment, it's really, as Shanta, I think, really said multiple times, we have a lot of co-occurrent issues when we treat people affected by substance use, so mental health disorders and trauma and other things. So one of the things that harm reductionists believe is that drugs have self-medicating properties, and we can't ignore that. We have to talk with our clients about that. What do they believe they're achieving, right? When are they using, and what is the result that they're trying to get, and really understanding that, so that drug setting framework is really important for that, right? What is the type of drug that the person is using, in what mindset and what setting, and how does that change the experience, right? So for example, a client could be okay drinking when they are out with colleagues and feeling good, right? And they can moderate drinking at that time. But if they are depressed or angry or sad, their ability to moderate drinking can be impaired. So thinking about kind of, what does the client have to adjust or give up to reach their goals? Maybe it's the type of drug, right? So maybe you could moderate one, but not the other. Maybe it's the setting, right? Maybe if I'm doing it in this particular setting, I could be okay and I could moderate my use. But if I'm using in another setting, I potentially cannot, right? And maybe it's mindset. I could use when I'm feeling happy, but if I'm feeling sad, depressed, that's where I get in trouble, right? So really thinking about what is the drug, the set, and the setting, and being open to differences, right? And not being able to moderate some, but potentially being able to moderate other type of drugs. And then in terms of assessment, a lot of the times what we say is thinking about the goals, right? And maybe redefining some of the goals. So substance use related goals could be abstinence, but they could also be at a particular time other goals, right? It could be safer use, it could be moderation, it could be drug substitution, right? So there could be a variety of different goals that we might work on with clients, right? And really exploring, as I've said before, what is the client motivated to do right now? They might not be motivated to be abstinent, but maybe they are motivated to have as more safe use practices, right? Maybe they are motivated to moderate their use. Maybe they're motivated to substitutions, right? So really thinking about those goals rather than having just abstinence, having other kinds of goals as well. It could be helpful to explore the adaptive functions of drugs and then talking about harms. Sometimes that puts a client at ease, kind of conveying that we understand why they might be using, right, and what that does. it doesn't necessarily mean that we're accepting, right? It sometimes it feels to clinicians, well, if I'm talking about the good things about drugs, that means I'm promoting drug use. But really, it's just thinking about what are clients really looking to achieve, right? And understanding them a little bit better. And then exploring substitutions. So once we know, for example, if a client tells you, well, I really just want to have all my concerns go away, right? I just wanted this numbing effect and just not to think about anything. Maybe we could think about other types of substitutions that will achieve the same goals with less harm. And yes, we want to promote not drug-related substitutions. Sometimes we have to be open to other drugs as a substitution as well, because if a client is not willing to be abstinent at this point, sometimes there could be other alternatives to explore with that client as well. And again, this is a quote I like: you cannot take away what you cannot replace, right? So we can't say, well, you have to give this, 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 and this up, and then not providing some kind of substitute. It doesn't have to be drug related, but we do have to address the needs that the client has and how can we meet those needs in other ways. So I wanted to stop here and just kind of ask Shanta and Kelly, how you do that in practice, right? Like how you help clients find safer substitutions, either drug related or not drug related, but how would you do that in a practice setting?
Hi, so I want to say I have to get off at 1:15 because I have a peer-to-peer emergency situation to keep a patient from discharging. So please excuse me when I depart. But I do want to say that how do I, again, going back to what are those underlying reasons why we use in the first place? A lot of it is the not having the proper coping skills or build up coping skills. It's hard when you are in the struggle and you couldn't eat as a child and your parents were nowhere to be around and you were watching your sisters and brothers and just barely having a place to rest your head comfortably without people coming out of your house. So, you know, we have to really understand where some people that, and knowing that's not always the case for all clients, do not misunderstand me, but that's just the case for most. So if we're coming from those, you know, backgrounds in a situation where we were exposed to things earlier in life, our ability to adapt and cope, what does that mean? Adapting, coping, what are you talking about? Are you kidding? I'm just trying to survive. So you need to really take those things into consideration and be very aware, just be conscious of yourself, but also be able to listen and receive and understand what they're not telling you, because they're numbing. What am I numbing myself for? Numbing from reality that I can't eat, I don't have money, I lost my children, I'm estranged from my family, no one likes me. I mean, so you can't take it all on at one particular time. But what I'm saying for me in my practice is when I work with patient privately or when I was in my last day at Rutgers today, by the way, sorry to inform you of that. But part of my experience in the care center is going to be also, we are needing to take a step back, ask them, you know, again, what's been happening with you, leave open-ended questions, but then also there's sometimes where you have to hit it pretty hard and go right on in and ask the difficult questions, because sometimes, but be prepared for what you're going to hear, because it's sometimes maybe you who don't want to hear the truth about what they're going through, because then you feel like, oh God, I'm stuck having to explore with them. Depends on the type of clinician you're getting. I can just speak for myself. I feel that I use both psychiatry with psychotherapy. I do like to dig deep. I do like to be an onion, the person's an onion, and we peel back these layers. It does not happen overnight. It may take a significant time. So just be patient, be open-minded, and get to the root of why we're numbing ourselves. And if we're going to recommend things, and I was going to actually bring this up, Svetlana, as far as recommendation, I know this is taking it a step from out of the office, but what I can tell you from covering both inpatient, outpatient, I am tired of seeing my patients who have a diagnosis very clear as day, opiate use disorder, substance use disorder. Oh, he's left and prescribed oxycodone, an opiate agonist. If I see one more chart, and I would tell you I get a lot of inpatient. That, and I'm like, do you think this 5 milligrams of a person who's used chronically for the last 30 years, this 5 milligrams is going to be sustainable for them? First of all, they've exceeded the opiate receptor, the ceiling. So please, if we could do anything in addition to stop using the words addict and dopehead, I would love if people could advocate for having a real true specialist, not people with just a ability to write for Suboxone, a person who understands how to properly prescribe at the appropriate doses and titrate them up or down and manage the patients with Suboxone. The other thing you can do is stop discharging people with these opiates. It's out of control, especially in the ER. You can also use alternatives, high-dose ibuprofen and the buprenorphine patch, which is like Suboxone, but a patch for chronic pain. I'm just going to put that out there that I hope that we can promote for the self advocacy for patients to empower themselves and say, you don't have to take that script. Just say no, because it's going to trigger you. It's going to put you back in those moments and when you're trying to feel numb, when you have now upgraded and taken care of yourself and have been abstinent, or you have been on Suboxone. Let's not revert back. Okay, so these are just things, because I know I'm getting off in 5 minutes, but I just wanted to share that and hope that we all can really please advocate for ourselves as a team, as a group, as a global community, to serve the people and meet them where they are. That's all I ask. Please.
Shanta. Yes, absolutely agree. Kelly?
So especially in regards to this, if you're an agency that employs peers, please lean on your peers in this aspect, because you're taking folks with lived or living experience, talking to someone about what they're using, how they're using it, right? If I have someone and they're telling me they're getting abscesses, they're having trouble, they're an IV drug user, they're having trouble finding veins, they're having the skin pot, like all these things, they don't know what to do. And then I have the knowledge to be able to talk to them. Have you thought about smoking it? You know, like different options. So I'm not telling you to totally stop, because you haven't told me that you want to stop, right? But I told them, I want you to be safe. I'm here for what you're looking to do. So exploring other options, alternating IV sites, you know, and you can literally see folks' eyes light up when you can have an open, honest discussion about their drug use and how to do it safer, because they don't hear that very often, you know, especially in a clinical field. Again, it's demand perfection. So again, if you have peers, please lean on your peers, because it's a different level of connection. We talk a lot about therapeutic alliance, but when, you know, I work with a lot of unhoused, actively using folks, and I always get, are you a social worker? I'm like, no. They're like, did you use? And I'm like, yep, yes. So like, you recognize the real in me recognizes the real in you, right? So that's credibility. So you're establishing credibility with your folks by looking at different ways to use and be safe. And I'll never forget these two folks I were working with were really concerned about abscesses, having a lot of problems using IV drugs. And then I saw them the next week, and they were so excited to tell me that they started smoking their drugs instead, right? And I cheered them on. Some people I told that to were horrified. And I'm like, you don't get it though. You don't get it. They're actively trying to do better. They're actively working on themselves. And I'm going to celebrate that every day of the week. So this is a huge thing. And having that knowledge to do that and to be there for folks so they can take all those masks off and just really be like, I care about you. I want you to be safe. Let's try and figure this out with you, not for you, with you.
Thanks, Kelly. Yeah, I think that's right. And a lot of clinicians are really uncomfortable saying, well, why don't you try smoking instead? Because to them, that is condoning drug use, right? That means that I am departing from that you shouldn't use at all. But I think you're absolutely right that you not using it all is not the goal that they said they're wanting to achieve, right? And for us to insist that that's the only goal is going to lead to losing the client at some point and them not being safe. and continuing to do something that puts them in harm's way. We are Serta. I want to leave a little bit of room for discussion as well and questions. So I'm just going to go through some of this a little bit quicker. As you kind of think about what Kelly just said, establishing a hierarchy of what the person wants to achieve right now is really important, right? Like, what's the most urgent but manageable goal for the client? Sometimes the manageability is the important piece. Maybe the most urgent would be to reduce chaotic heroin use, but they're not there yet. Maybe safe and stable housing is right now the most manageable goal for them, right? They could potentially enter a program and they're okay with that. So establishing that hierarchy and sort of figuring out what is the client's first priority at this point. And Kelly just said this, I can't say it any better. Safer use counseling, right? And really getting trained on how to talk with clients about safer use, even when they're not willing or able to commit to abstinence, right? So what is the safer use practices that we might be able to discuss with our clients? And that could be naloxone, that could be supply testing, if sometimes presence of fentanyl is not necessarily going to change anything, but if it would, it's important to do that and introduce some of those strategies to clients. But certainly safer injection techniques and safe storage education and things like that, that have some real implications, right? Like if this is a person who potentially has access to children, right? Safe storage is a really important thing. And that's something that we really have to talk with clients about. And then, as I've said before, starting with low threshold strategy as an agency, right? And then getting staff buy-in, because if the staff are not on board, it's not going to happen. So maybe the staff is not on board with talking about safer injection techniques, but they are on board with safe storage education. Great, start there, right? They are on board with supply testing or naloxone. Fantastic, we're going to do that, right? And then we can see what kind of effects that achieves, and maybe staff are going to be more willing to have other conversations later on if they see the benefits to clients. Trauma, Shanta mentioned this, is really common. And this issue of first do no harm is really important. Some of the clients that I've spoken to, and I'm sure Shanta and Kelly have seen in their practice, say that treatment traumatizes them because of some of the intrusive, shaming, stigmatizing questions that clinicians sometimes ask because of controlling techniques and things like that. And that is just one more reason for them to say, I'm out. I don't want to be doing this at all, right? Because this is not a safe space for me. So I don't know if you have time to just briefly talk about re-traumatization by service providers and some of the things that you see in your practice and what to avoid. Maybe we could just spend 1 minute on it, and then we'll leave 10 minutes for questions after that.
I apologize. Like I said, I'm waiting for this call for this peer-to-peer, so I'm still on. But yeah, I want to definitely say that if someone is not ready to be at that point of where they're really to open that suitcase or peel back that onion, there's no rush. I've had clients, I think, already had the thought based on some of the things they may have shared with me or not really gave me any details or even close to, but I kind of can just, I had the kind of that intuition, that feeling. And a year and a half later is when he shared with me about his significant, but that's a year and a half into treatment. That wasn't the first day. That wasn't a month later. That was building that trust to where he just said, one day I've been wanting to tell you something. And there he went. And that is how it comes out. And that was I give them the control of that. I am letting them know that I have experience with folks who have different walks of life. I just kind of give them scenarios or situations and also other examples. And then when they realize, oh, this is not maybe the first time you've heard this, it makes people feel a little bit comfortable. But storytelling, healthy, appropriate storytelling, without disclosing of HIPAA or anything like that, but just also letting them, make them aware, and also show a little human side to yourself. Be human. Be human. That's all I can tell you. Be human, and it will all come. It comes in time, but be patient.
Oh man, I'll be brief, but I could speak on this for a week and a half. Trauma, first of all, again, language. How are we talking to folks? And how are we asking them those questions? And also, are we dictating their pathway for them, right? And then if someone is always having outbursts or something in treatment, and then they're just labeled as difficult, that outburst says more about them and that they need something than it does about, you know, the clinician or whatever the thing may be. So let's work on de-escalating that. Is your treatment center actually accepting of the LGBTQIA community? And I'm not saying you got a little flag in your window. Do you have staff? Is there diverse representation? All of that can be traumatizing, because if folks don't see themselves, right? If they're not seeing themselves, then that's another internalized stigma on them. Like, nobody here is like me, acts like me, looks like me. This is a waste of my time. And, you know, look at how, like, what are some of the ways that folks are coming into your facility? You can come for me if you want, but there's a lot of police-led funding initiatives that treatment centers have. Police cause a lot of trauma for our folks. So just them being around can be traumatizing, and they're not going to utilize care or speak to folks that really want to help them, because they automatically have that trauma sneaking back up just from the sight of different things. But that was brief. That's all I got.
Okay, well, we're 10 minutes. Thank you, Kelly and Shanta. We're 10 minutes before we have to end. So I think maybe this is a good time to open it up for questions. And then if we have a few more minutes after that to finish our slides, we will do that. But any questions, anything, any thoughts?
Dr. Spiegel, thank you so much. And as questions roll in, I just want to share a couple of things. I really appreciated, you know, in the beginning, you sharing that slide that said, like, what are you willing to work on? What is your motivation? And I think so often, even if it's unintentional, we begin to impose what we want for the client and what we think is best, rather than working with the client and helping them identify their goals and then working towards those goals. And I think all of us will see better outcomes or just more success if we're actually working towards the client's goals rather than what we think their goals need to be. And I think celebrating those small wins that you were talking about, Kelly, no matter what they are, and working through those harm reduction principles, having your client just achieve one small thing that they wanted to achieve can greatly impact their self-efficacy. And who knows, you know, someone who's practicing harm reduction today could even transition to abstinence once they can believe and see that they can exist and they can live without the substances, without drug use, without harmful use, whatever it may be. It doesn't always have to look the same. It could start one way and end, you know, in a totally different orientation and a totally different philosophy. So it's all about the client and just making sure you understand what they need and what they want and how you can help achieve that. That's a moral obligation, I think, for all of us in this field, not imposing our views and our, you know, principles, but rather keeping the client first. James has his hand up. James, did you have a question?
Yes, I didn't have a question. I had a statement that Kelly LeBar, I truly appreciate you. You're one of my supervisors in the field of harm reduction. Ruby Clark is my boss for Ruby Vision. And I'm glad that the nation, the cities are accepting the harm reduction and accepting peer recovery specialists today. Because for me, out of my 40 years of using, counselors get on my nerves. You know, I'm just telling you me. You know, I mean, they get on my nerves because there's always a punitive action for what they're doing. They always want control of your life. They tell you what you could and you cannot do. And most of the time they coming from the book without the experience. You know, you can get in the book, but you don't know about me in that abandoned house. You don't know about me in that prison cell. You don't know about me in that dope gallery or that crack house. You know, you never experienced, but you keep telling me what I need to do. You know, you're not making no suggestions for me. You don't have no goals for me. You just telling me to get off this drug. But I've been on this drug for 40 years. My behavior is totally different than it was when I first started, you know, using the drug. So I'm just glad to be on here today. Kelly, I'm glad to listen to you because, you know, we be in the trenches together and you're very informative. I thank all y'all and God bless you.
Thank you. Mary Elizabeth, did you have a question? You're muted.
The worst thing that can probably happen is for me to unmute. But I think it also, harm reduction strategies and their use include giving clients opportunities to shine through the arts or for ability to demonstrate things that they do well and creatively. And I think to a large extent that gets a limited bang for the buck. And I think we need to be doing that. The other thing is, my belief is that harm reduction strategies promote honesty in the folks who have a listening ear themselves, and it reduces chronic denial. That's really a huge goal. Oh, I'm so glad to see some of you shake your heads because you know what you're doing. I don't.
Thank you. Becky, you have your hand up. You can unmute, please.
Hi, yeah, I just wanted to, first of all, Kelly and Shanta, incredible presentation, and Svetlana, you guys are, I think everything that you were presenting is very achievable. And, you know, you guys were really treating us in the same harm reduction mindset that you treat your patients, which I really appreciate. I did just want to respond to what James said. I am a social worker. I'm a manager now, but nowhere in my training have I ever been told to tell a patient what to do. But we are in society conditioned to believe certain things about people who use drugs. And I think as a white person, and a counselor, you know, working with patients who are, you know, I grew up in the suburbs of Long Island. I'm very aware, or have attempted to be very aware of my privilege in those moments when I'm working with patients who are often people of color, you know, raised in low income inner city areas. And I think a lot of it is when, like, even Svetlana, when you were saying someone's uncomfortable in a room when a patient comes in high, I'm like, why am I uncomfortable with this? Is it because I've been conditioned to be uncomfortable with this, or do I actually feel like I'm in danger? And I know for a fact that that patient that's like falling over, you know, maybe they're high and nodding out, they are in no condition to hurt me in any way because they are not able to stand. But B, I know this person and they would never want to hurt me. We've built a rapport. We have this. So why do I feel uncomfortable in this space? You know, is it me? Is it them? Like that in that situation, it's all me, right? So I think we as people who are working in this field just constantly need to check ourselves, because I think a lot of times the feeling it has nothing to do with the patient. It's all of like the societal conditioning and what everyone else is telling us we should think in that moment.
Thank you. I'd like to ask a question, you know, anyone on the panel, what would you say to the individuals or groups that might say that harm reduction opposes treatment necessarily, or that it wipes out the need for treatment?
Kelly, Shanta, you want to weigh in on that?
I apologize. I thought it was to the audience. Repeat that. I apologize, Amanda. I'm sorry about that.
What would you say to the group of people that say that harm reduction principles or practices wipe out treatment, or they take away the need for treatment, what, you know, has been abstinence-based treatment or any form of substance use treatment, that if someone can, you know, just practice harm reduction and continue to use, there's no need for treatment?
I don't know. I think that I think people should have the options. There are some folks that who I have that in treatment currently that told me that the reason why they don't go to some NAE meetings is because they were told that they're not really sober because they're on Suboxone. I don't necessarily agree with that. I think we all have different roads to get to where we need to go. You know, each chapter in the book is going to be a little bit different, but that's your book, not mine. And how dare I influence or infringe my personal thoughts and values just because it doesn't work for me? And that's what I believe. They call it old school thinking. I call it, let's just, you know, knock some sense into your head and be respectful of other people's choices. That's what I think. So I don't necessarily think abstinence completely the way for some people, and then Suboxone and medication assisted treatment works for others. It's whatever works for you to get you to a better place, however it's defined by you. That's also within the thought and constraints of what's happening in your society, what's happening in your world. What is it that we can do to make the situation better? And you are going to be included in making this community or our situation better. So how can we do this together? So I don't really, that's my thoughts.
Thank you for asking this question. Someone always asks this question, so I was like waiting for it. So I'm like pumped. So, first of all, just that like idea separates everything, right? Not talking about harm reduction, treatment, medication, like how we all have to work together. But if someone's like, you know, I don't really, it needs to be treatment, not harm reduction focused, they're uncomfortable with it. A lot of people, conversations recently, very uncomfortable with the option of OPC, Overdose Prevention Center. And my response is always, are you comfortable with over 100,000 people dying of overdose? Are you comfortable with people dying in alleys and gas stations in their bedrooms alone with their families downstairs because they're too shamed because they have to hide and isolate? That's what you should be uncomfortable with. That's what you should be upset about. So the more options we have for people to bring everything they're doing to light and have that support, and also recognizing, you know, we're talking about drug use, we're talking about a whole person. If you actually go out, do outreach, you know, James was talking, James can agree with me on this. How many of you have reversed an overdose, right? Compared to how many people that use drugs currently and actively, how many lives have they saved? And I pump them up every time I see them because it's just like a Tuesday for them. Yeah, so-and-so, I brought them back, right? No, you saved a life. You're a hero. You're out there doing it. You're taking care of your community. So, you know, on a positive note for this, you know, people discount that people use drugs, just period. Use drugs, period. You need to be in treatment. You need to this. This is saying you have the autonomy. I'm going to help you get to treatment if you want, use safe if you want, but most importantly, I don't want you to die. And I'm going to be alongside you no matter what is going on to help you through it. And I'm also going to recognize any progress that you're doing. And if you're not making any progress and completely down on yourself, I'm still going to pump you up 100%. And it needs to be all of us, treatment providers, referring to harm reduction services, harm reductionists, referring to treatment services. All of us need to come together in this because we're losing so many people. So like we keep talking about being uncomfortable, please be uncomfortable. That means you're growing, you're moving through stuff that's stagnant and needs to be moved.
Thank you.
And Shanta.
One
Yeah.
last question, if any. Sorry, Dr. Spiegel, go ahead.
No, go ahead. Go ahead, Aman. We don't have a lot of time.
Are those practicing harm reduction, is that recovery?
That's a really good question. And, you know, I'll let Kelly and Shanta speak from the field's perspective, but just from my perspective, it's really what do we define as recovery? Is recovery abstinence, or is recovery having a better, safer, more productive life, right? So how do we think about that? But I want to give Kelly and Shanta the opportunity here, because they're the real experts. We're just a university that coordinates this. The experts is them.
You know, it's definitely self-defines, you know, so short answer, yes, 100%. but like we're talking about positive changes, any positive change. You know, recovery has kind of been co-opted to mean abstinence only. Generally speaking, okay, generally speaking. But recovery is harm reduction, recovery is any positive change, recovery is like what you want it to be, recovery is maybe not using opiates, smoking weed every day, manage your anxiety. I don't care what it is. If you're active, you're trying to do something better, trying to work on yourself, you're in recovery when you say you are.
Yes, and recovery does not necessarily have to be complete abstinence. Recovery is a lifelong process, really. I've had, again, patients who may have been sober for 27 years. Mom passed away, sister passed away, and a lot of things happen, and they remember those feelings of being uncomfortable. But then where they felt they had to turn back to some substance to coat. I didn't say cope. I said coat. To coat themselves from protecting that numbness that you're talking about, that takes them away from what they have to feel. So coping skills, developing loving self again, accepting and forgiving will be part of this recovery. And it's a daily walk. It's not one thing. It's not 1 year. It's a step every single day. That's my intention.
Thank you.
So much.
I want to thank all of you for, I want to thank our panelists first for just putting together such an amazing presentation and being available to deliver this information, and also all of our attendees for joining us today and just having a robust discussion. Thank you so much for just being here. We will share these slides from this presentation with everyone who was registered. And you will all receive a link for a brief survey just after, confirming your attendance and some other questions. In order to receive your continuing education credits, you'll need to complete that survey, and then you'll receive your continuing education certificate via email in the upcoming weeks after you complete the survey. So thank you, Dr. Spiegel, Shanta, and Kelly, again for just being here today and providing us with this information. Everyone have a great day, and avoid the rain if you can.
Thank you so much. Thank you. Take care. And Shanta and Kelly, thank you so very much for joining. This was amazing. I appreciate this.
Thank you all so much. Happy end of recovery month. Support your local syringe exchanges. Have a great weekend.
Take care.